I'd like to show my disclosures first, that I do receive advisory fees from Terumo Blood and Cell Technologies, from Fresenius Kabi, and also I'm a part of the Medical Advisory Council for the American Red Cross. Well, Dr. Escolar has beautifully described to us in vitro ways of evaluating pathogen-reduced platelets. One can also evaluate them in vivo in research subjects, and I'm going to show you some of that data. Then there are observational trials. There's the experience from routine use, which we are going to hear about later from 3 physicians who have considerable experience. There are hemovigilance studies, and there are randomized controlled clinical trials. And that's what I'd like to spend the next few minutes discussing, because those are the most highly structured way of looking at the clinical use of these pathogen-reduced platelets. So what kind of factors are analyzed in these randomized clinical trials? Well, currently, the most important aspect of all of this is bleeding and the effect of the pathogen-reduced platelets in controlling bleeding. Now, one can look at the percent of patients who bleed, or the duration of bleeding, or the location of the bleeding, and I'm going to show you some of this data. These randomized trials compare the different kinds of platelets. They might be apheresis or Buffy-coat or a mixture in different trials. The number of platelet transfusions can be evaluated during the study time, and the time to the next platelet transfusion. The duration of platelet support of these patients on the trials, and the use of gamma radiation. In addition, the age of platelets at transfusion is documented in these trials so that we can tell whether this has a clinical impact. Corrected count increments are another way of looking at the outcome of the platelet transfusions, but we're going to talk a little bit about how that is only moderately helpful. And of course, adverse events can be tracked to evaluate the safety of these pathogen-reduced platelets. There have been thus far 10 randomized clinical trials of pathogen-reduced platelets. 7 of these involve intercept platelets, and 3 involve myrisol platelets. These studies have been published between 2004 and 2019. So these 10 trials were published over a period of 15 years, a rather long time interval, and we can expect that to some extent the management of these patients has also changed over that period of time. But these 10 trials have all been prospectively randomized. They have used controls of standard platelets and compared these with pathogen-reduced platelets. In general, the patients in these 10 clinical trials were similar. They were mostly hematologic malignancy patients who were either undergoing chemotherapy or stem cell transplants. The duration of these trials was considerably different. Some trials were completed in only about 2 years, and one trial took about 7 years to complete. The trial size has a wide range, which I'll show you in a few minutes, and the endpoints were different. So while these are highly structured ways of evaluating the clinical use of these pathogen-reduced platelets, it's difficult to, there are quite different variations in how these trials were done. Let's start with just the numbers of patients studied, first of all. In the 7 trials of intercept platelets, the range of numbers of patients in the control arm was 21 to 327. So you can see there's a large difference in size of these trials. The pathogen-reduced patients in these 7 trials range from 22 in one trial to 318 in another trial. And the total number of patients in these 7 clinical trials of intercept platelets was 1,972. So there's considerable experience in clinical trials of intercept platelets. Myrisol platelet transfusions involved 3 studies. The control patients in those trials range from 54 to 279 in one trial, for a total of 430 patients. The pathogen-reduced numbers of patients in these trials range from 56 to 277. And you can guess that the smaller numbers there, the 54 and the 56, that was one particular trial in which there were 54 controls and 56 patients in the pathogen-reduced arm. And the larger number also was the same particular trial, 279 controls, 277 pathogen-reduced patients in those studies. But the conclusion from this, first of all, is there's a wide range of trial size, and the totals of the control and the pathogen-reduced patient products varies, but was quite similar in each particular trial, as illustrated by the numbers at the end of the range of each of these trials. So the other important factor now in considering the clinical experience is the endpoint of these clinical trials. In the INTERCEPT trials, 4 of the studies used bleeding as their endpoint. 3 of the trials used corrected count increment following transfusion. In the MIRASOL 3 studies, 2 involved bleeding and 1 involved the CCIs. So we'll look at this in a little more detail now. This slide shows the experience with platelet transfusions in these trials. And the top group shows the range of the numbers of platelets transfused during the trials. And you'll see with the INTERCEPT trial in control patients, the number of platelets transfused during the trial had quite a large range, 101 to 2,041. MIRASOL had similar experience, 310 to 1,568. But if you look at the next line down, the number of pathogen-reduced platelets, 101 to 2,678 in the INTERCEPT studies, 368 to 1,659 in the MIRASOL trials. So there were more platelets used in the pathogen-reduced patients compared to the controls. Next is the total number of platelet transfusions, and we see the same sort of thing. If you look in the INTERCEPT data, 4781 versus 5745. So more pathogen-reduced platelets were used. The same experience with MIRASOL, 2212 versus 2484. More total platelet transfusions were done in these clinical trials in patients who received the pathogen-reduced platelets. The number of transfusions per patient shows us the same kind of experience. In the INTERCEPT arm, the range was 4.1 to 6.2. The range for the pathogen-reduced transfusions, 4.1 to 8.4. Similar differences for the MIRASOL platelets. So there were more transfusions per patient in patients receiving the pathogen-reduced platelets. Now I want to point out, it isn't real clear from this data, by saying more, this amounts to about 1 more platelet transfusion during the entire clinical trial. So this is not a huge number. And the last group of data here shows the interval or the time to the next platelet transfusion. MIRASOL 2.4 to 3.4 days versus 1.9 to 3.0 for the pathogen-reduced transfusion arm. The same difference for the MIRASOL transfusion. So there was a shorter time between transfusions in these controlled, rigidly monitored clinical trials. But what about the outcome of the transfusions, which is what we're really concerned about here? And the top set of data shows the rate of bleeding of grade 2 or greater in patients. And the INTERCEPT trials in the pathogen-reduced, in the patients receiving pathogen-reduced platelets, the percent of patients with grade 2 or greater bleeding ranged from 13 to 64. The range for the control patients was 4 to 71. In the MIRASOL studies, the range of pathogen-reduced patients' percent of bleeding was 13 to 54, and in controls, 9 to 51. So the key point here is the likelihood of bleeding was the same in patients who received pathogen-reduced platelets compared to those who received ordinary standard platelets. The next group of data shows the number of red cell transfusions per patient. And the short answer here is this is also the same. You can see under Intercept 3.8 to 8.2, 3.7 to 9.3, the likelihood of receiving a red cell transfusion was the same in patients who received pathogen-reduced platelets versus ordinary control platelets. Let's look at safety for just a minute. Transfusion reactions in the Intercept, 1.8 to 6%, 2.1 to 6.1%. Mirasol platelets, 0.3 to 7% versus 0.3 to 9.9% for controls. So again, the message here is very clear. For safety purposes, the rate of transfusion reactions was no different in patients receiving pathogen-reduced platelets compared to those receiving ordinary standard control platelets. I'd like to show you specific data from one of these studies. This is the study called IPTAS, the Italian Platelet Technology Assessment Study. This was a really interesting clinical trial in that it was carried out at 6 different centers in Italy. In 3 of those centers, Mirasol platelets were compared to standard platelets. And the other 3 centers, Intercept platelets were compared to standard platelets. But this was carried out as one homogeneous study. It was not designed to compare the 2 different pathogen-reduced technologies, but yet for convenience sake, to use the same structure, the same clinical trial to gather data about both of these technologies. So if we look at the first line, grade 2 bleeding, that's the number of patients who experienced grade 2 or greater bleeding during the trial. In the Intercept arm, 22% in the pathogen-reduced group, 15.9% in the control group. In the Mirasol arm, 13.4% in the pathogen-reduced group, 9.3% in the control arm. These numbers are not statistically significantly different. So the conclusion of this IPTAS study is that bleeding is no different in patients who receive pathogen-reduced versus control platelets, and this applies to both technologies. If we look at more severe bleeding, grade 3 or 4, in the next line down, you see 0, 1, 1, and 2. So there's almost no severe bleeding in the patients who participate in these clinical trials, and it is certainly not different between those who received pathogen-reduced versus control platelets. Now let's look at the number of days of grade 2 bleeding. So if patients don't bleed anymore, if patients are not any more likely to bleed, when they bleed, do they bleed longer? The answer here also is no. 4.8 days versus 3.6 days for Intercept, 2.3 versus 4.3 for Mirasol. So the likelihood of bleeding is no different, and the duration of bleeding is no different. But let's look at the number of transfusions per patient, because these are different. In the pathogen-reduced arm of Intercept, 5 transfusions per patient versus 3.8 in the control arm in those studies, in this study. For Mirasol, 4.6 versus 3.9. So this is statistically significantly different. And this is what caused me to say earlier that while patients in the pathogen-reduced arm of these trials do receive more platelets, this amounts to about 1 transfusion in the approximately 1 month duration of these clinical trials. But now let's turn to the corrected count increment following transfusion. And there are differences here. You see in the Intercept trials, the 1-hour CCI in this study was 9,400 compared to 11,300 in the control arm. In the Mirasol 3 centers, pathogen-reduced patients had a CCI of 12,400 versus those receiving control platelets of 7,600. I'm going to show you more data related to this on the next slide. The transfusion intervals were also slightly different. For Intercept, 2 versus 2.5 days between transfusions. For Mirasol, 1.8 versus 2.3 days for transfusions. So we have a slightly shorter interval between transfusions, but this amounts to maybe on average 1/2 day during the clinical trial. So I want to show you this data which relates to the corrected count increment. This is the recovery and survival in vivo of pathogen-reduced platelets in healthy research subjects. These subjects donated platelets, and on one occasion, they were not treated, stored, and transfused back to the donor. On another occasion, they were treated with either Mirasol or Intercept and then transfused, and radio-labeled studies were done to determine the recovery and survival of these platelets. So the top set of data shows for both Intercept and Mirasol the recovery. For the control patients in the Intercept arm, there was a 50.3% recovery versus the pathogen-reduced platelets had a 42.5% recovery. So lower recovery in vivo of the pathogen-reduced platelets. For the Mirasol trial, this was the same, 66.5% recovery in controls versus 50.3% in the pathogen-reduced platelet transfusions. So recovery was lower. Survival was also shorter. If you look at the controls, 6 days versus 4.8 days for Intercept, 142 hours versus 104 hours for Mirasol. So we have lower recoveries and shorter survival. So it is not surprising then that the corrected count increments following transfusion in these clinical trials would be lower. And that's illustrated in the bottom part of this slide for the aggregate of all 10 of these clinical trials. The CCIs in control patients in the Intercept studies range from 9,400 to 16,000 versus the pathogen-reduced platelets gave CCIs of 8,100 versus 13,000. The same difference in the Mirasol arm, 13.7 thousand to 21,000 range in the control transfusions, 11,700 to 12,400 in the patients receiving pathogen-reduced platelets. So I'm going to summarize this in a few minutes, but the message from these several slides is bleeding is equally well controlled in these randomized trials by pathogen-reduced compared to standard control platelets. These research studies shown on this slide in healthy research subjects suggest that there are lower recoveries and shorter survivals, which probably means that there might be more platelets used and there might be a shorter interval to the next transfusion, and that's exactly what was shown in this aggregate of 10 clinical trials. Having said that, I want to say once again, these numbers end up in an actual clinical trial being relatively small. Patients may receive one additional transfusion of pathogen-reduced platelets, and the transfusions may be given at about a half a day shorter interval. So while this is different, it is a relatively minor clinical impact. Just the next two slides are just to give you an impression of the number of patients involved in the Mirasol studies in these clinical trials. I mentioned there have been 3 randomized clinical trials of Mirasol platelets. They're listed here: the Miracle trial, the IPTAS, which I just showed you, and the Prepares trial, which was a large, very well done clinical trial done in the Netherlands, Norway, and Canada. And that had the largest number of patients. You see on the right side, 556 patients. So there have been a total of 862 patients involved in these 3 randomized, highly structured controlled trials of Mirasol platelets. In addition to that, there have been a number of observational studies of Mirasol platelets briefly mentioned in this slide. And I'll put this in here to show you in the middle column of objectives the types of things that were studied in these observational studies. First is storage duration, comparing 5 to 7 day storage. The next is experiencing pediatrics patients. The third one down is comparison of platelets stored in PAS versus plasma. That's pathogen-reduced platelets stored in PAS versus plasma. The next is a trial of Mirasol platelets in stem cell transplantation. And then evaluation of corrected count increment in clinical use. And the last 2 also evaluating routine use. So there has been very good practical clinical experience with these trials. with these pathogen-reduced platelets. We're going to hear more about that in a few minutes from our panel. So what are the conclusions from these 10 structured clinical trials of pathogen-reduced platelets? Well, first of all, the size of the studies varied considerably. Some were rather small, some were quite large. The bleeding rates in the controls varied quite a bit. You may recall from some earlier slides, some of these trials had a bleeding rate in the controls of maybe only 10 or 15% of patients who experienced bleeding. And others, one trial I was involved with some years ago of intercept platelets, the bleeding rate was, I think, 58% in controls. So there's quite a range of bleeding. And the mixtures of patients were used. Some of these trials involved Buffy-coat platelets, some involved apheresis platelets, or unfortunately, some trials used both kinds of platelets. More platelets were used in patients receiving pathogen-reduced platelets. There was a shorter interval between transfusions, but I've already mentioned these differences are small. Corrected count increments were lower in patients receiving pathogen-reduced platelets, and we expected this from the research subjects on healthy human volunteers. There was a higher rate of refractoriness, but this did not seem to relate to any increase in bleeding because there was no increase in grade 3 or 4 more severe bleeding, nor more use of red cells in patients receiving pathogen-reduced platelets. So in conclusion, pathogen-reduced platelets are equally effective in controlling bleeding. There is no higher rate of severe bleeding in patients receiving pathogen-reduced platelets. There's no higher use of red cells in these patients, and there's no difference in the adverse event rate, suggesting that the safety of these pathogen-reduced platelets is similar to ordinary control platelets.